Critical thinking in psychiatry. Most trainees in psychiatry are told about the importance of critical thinking. However, they are not often educated about the concept's key components or what exactly it means. Some have been led to understand that critical thinking is about how to analyze research publications. Conceptual anchor: critical thinking involves systematic processes. It is a disciplined and self-directed activity that requires active engagement with information. When thinking critically, we skillfully conceptualize, apply, analyze, synthesize, and evaluate information. This information comes from various sources: our observations, experiences, reflections, reasoning processes, and communications with others. The ultimate purpose of critical thinking is straightforward: to guide our beliefs and actions towards greater clarity, accuracy, and fairness. Relevance to psychiatry. Unlike other medical specialties with their arsenal of objective diagnostic tools, psychiatry operates in a realm of profound subjectivity. In our field, there are no definitive blood tests that confirm depression, no imaging studies that conclusively diagnose schizophrenia, and no biomarkers that neatly validate anxiety disorders. Instead, we rely on clinical judgment, reports from team members, patient narratives, and observed behaviors. These can be heavily subjective forms of evidence. This makes critical thinking absolutely essential to psychiatric practice. When a patient describes hearing voices, we must carefully consider multiple interpretations. Is this psychosis, a spiritual experience, an idiom of distress, or perhaps a metaphorical expression? The answer requires more than diagnostic criteria. It demands a thoughtful synthesis of cultural context, personal history, and clinical presentation. The ethical dimensions of psychiatry further elevate the importance of critical thinking. Our decisions carry profound weight, whether determining if someone lacks capacity for certain decisions, weighing the risks and benefits of psychotropic medications, or assessing suicide risk. Each decision requires us to navigate complex ethical terrain where autonomy, beneficence, and justice often exist in tension. We must question our own biases and assumptions, asking whether our interventions truly serve the patient's needs. In practice, a psychiatrist may be unaware of whether they are service organizational needs or political purposes ahead of patient needs or risk-related matters. These ethical complexities cannot be resolved through algorithms or protocols alone. They demand the rigorous application of critical thinking. The NHS context presents unique challenges that further underscore the need for critical thinking. Working within resource constraints, we face constant pressure to make rapid decisions. Yet, as Daniel Kahneman might observe, this pressure pushes us toward fast thinking, when many psychiatric situations demand the deliberate analysis of slow thinking. When facing high caseloads and limited time, we risk falling prey to cognitive shortcuts, confirmation bias leading us to fit symptoms into familiar patterns, or availability bias causing us to overdiagnose conditions we've recently encountered. The diversity of the UK population adds another layer of complexity, requiring us to critically assess how cultural factors influence both presentation and interpretation. A patient's reluctance to discuss emotional difficulties might reflect cultural stoicism rather than lack of insight. Somatic complaints might represent culturally sanctioned expressions of psychological distress rather than somatization disorder. Perhaps most fundamentally, critical thinking in psychiatry serves as a bulwark against both overdiagnosis and therapeutic nihilism. In an era of increasing medicalization, we must critically question whether human suffering always constitutes disorder or might sometimes represent appropriate responses to difficult circumstances. When a bereaved person shows symptoms that mimic depression, critical thinking helps us distinguish between pathology and normal grief. Conversely, when faced with complex or treatment-resistant conditions, critical thinking prevents us from surrendering to therapeutic pessimism. It drives us to re-evaluate our formulations, consider alternative approaches, and maintain therapeutic optimism grounded in evidence rather than wishful thinking. In this way, Critical thinking helps us navigate between the scylla of overtreatment and the charybdis of neglect, a navigation that lies at the heart of ethical psychiatric practice in today's NHS. Critical thinking is deeply relevant to the practice of psychiatry in the UK, as it underpins clinical decision-making, ethical practice, and patient care. Good critical thinking enables clinicians to navigate diagnostic complexity, ethical dilemmas, and systemic challenges while providing patient-centered care. It extends beyond logic to encompass cultural awareness, ethical reasoning, and metacognition, skills that are particularly vital in the NHS's diverse and resource-constrained environment. By fostering these abilities, psychiatrists can enhance clinical outcomes, reduce disparities, and uphold the values of the profession. Key constituents of critical thinking. Critical thinking in psychiatry represents far more than logical analysis. It encompasses a rich tapestry of cognitive and metacognitive processes. These processes enable us to navigate the inherent complexities of mental health assessment and treatment with rigor and compassion. I explore what I think are the essential components. Analysis and synthesis, the foundation. At its core, critical thinking requires both breaking down and building up information. When we analyze, we dissect complex presentations into their constituent elements, separating symptoms from contexts, distinguishing between primary and secondary features, and identifying patterns within seemingly disparate behaviors. Consider the patient who presents with irritability, reduced concentration, and disturbed sleep. Analysis involves separating these symptoms from one another and questioning each independently. Is the irritability situational or pervasive? Is the concentration difficulty worse at particular times? What exactly characterizes the sleep disturbance? Yet analysis alone would leave us with fragments. Synthesis involves reconstructing these elements into a coherent whole, recognizing relationships between symptoms, and generating hypotheses that explain complex presentations. It is through synthesis that we might recognize how our patient's irritability emerges primarily when fatigued, how concentration worsens with increasing anxiety, and how disturbed sleep creates a vicious cycle with daytime symptoms. This interplay between breaking down and building up information allows us to construct meaningful formulations rather than merely listing symptoms. It transforms diagnosis from a taxonomic exercise into a meaningful understanding of a person's experience. Evaluating evidence, beyond acceptance. Critical thinking demands that we assess the quality, credibility, and relevance of information rather than passively accepting it. In psychiatry, this evaluation applies not only to research evidence but also to the clinical evidence before us. We must question the reliability of patient narratives while recognizing that inconsistencies may reflect genuine difficulties in articulating experience rather than deliberate deception. We must scrutinize our own observations, acknowledging how confirmation bias might lead us to notice behaviors that confirm our working diagnosis while overlooking contradictory evidence. This evaluative stance extends to formal evidence as well. When NICE guidelines recommend particular interventions, critical thinking encourages us to consider the populations in which those interventions were studied and whether they truly match our specific patient. When pharmaceutical trials suggest efficacy for a medication, we must critically assess whether statistical significance translates to clinical significance. This questioning stance doesn't imply cynicism but rather a commitment to ensuring that evidence truly applies to the unique individual before us. It acknowledges that evidence quality exists on a spectrum, and that even gold standard research may have limited applicability in certain contexts. Contextual awareness, the social dimension. Perhaps what most distinguishes critical thinking from mere logic is its attention to context. In psychiatry, symptoms never emerge in a vacuum, they are embedded within cultural, historical, and social contexts that shape both expression and interpretation. Critical thinking requires us to maintain awareness of these contextual factors and consider how they influence our assessments and interventions. When a young British Asian woman describes feeling suffocated by her family responsibilities, contextual awareness prompts us to consider cultural expectations around family obligation, intergenerational tensions between collectivist and individualist values, and gender roles within specific communities. Rather than immediately pathologizing her distress as adjustment disorder or depression, we might recognize it as an understandable response to genuinely difficult circumstances. This contextual awareness doesn't mean abandoning psychiatric frameworks, rather, it enriches them by situating symptoms within lived experience. Similarly, socioeconomic context profoundly shapes mental health. Critical thinking requires us to consider how poverty, housing insecurity, and employment precarity might contribute to presentations that superficially resemble psychiatric disorders. When a patient struggles to adhere to treatment, contextual awareness prompts us to ask whether practical barriers, transportation costs, childcare responsibilities, and stable housing might explain this non-compliance better than lack of insight or motivation. By maintaining this contextual awareness, we can avoid the trap of reducing complex social problems to individual pathology. Emotional intelligence, the affective component. Critical thinking in psychiatry cannot be divorced from emotional awareness. Our emotions and those of our patients influence the therapeutic relationship, diagnostic formulations, and treatment decisions. Rather than pretending to achieve perfect objectivity, critical thinking acknowledges these emotional currents and examines their impact. This emotional intelligence operates bidirectionally. We must recognize how patients' emotions might color their self-reports, how shame might lead to minimization of certain symptoms, how fear might manifest as hostility, how desperation might drive exaggeration. Simultaneously, we must attend to our own emotional responses, how frustration with a challenging patient might lead us to overlook important information, how anxiety about risk might drive overtreatment, or how personal experiences might create unexamined countertransference. By incorporating emotional intelligence into critical thinking, we transform what might be dismissed as subjectivity into valuable clinical information. A patient who consistently evokes irritation across multiple professionals provides important information through this emotional response. Our own unexpected emotional reactions to patients often signal unconscious recognition of important dynamics that merit conscious examination. Critical thinking thus incorporates rather than excludes emotional data, recognizing that effective responses often contain crucial insights when properly examined. Metacognition, thinking about thinking. Perhaps the most sophisticated aspect of critical thinking is metacognition, our awareness of and reflection on our own thought processes. In psychiatry, metacognition enables us to recognize our cognitive biases, question our assumptions, and modify our thinking patterns. It represents a form of intellectual humility that acknowledges the limitations of our perspective. This metacognitive stance helps us recognize common cognitive pitfalls in psychiatric practice. We become alert to diagnostic momentum, where an initial provisional diagnosis becomes increasingly difficult to dislodge despite contradictory evidence. We notice when availability bias leads us to overdiagnose conditions we've recently encountered or studied. We recognize when our thinking narrows prematurely, excluding alternative explanations before they've been adequately considered. Metacognition also enables us to balance confidence with humility, to make decisions with appropriate certainty while remaining open to revision. When a patient fails to respond to treatment as expected, metacognitive awareness helps us question our initial formulation rather than attributing lack of progress to the patient. This reflective stance embodies the scientific method at its best, forming hypotheses, testing them through intervention, and revising them based on outcomes. Through metacognition, critical thinking becomes not just a skill but a disposition, an ongoing commitment to examining and improving our own reasoning. Thinking fast and slow, Kahneman's dual processes in psychiatric practice. Daniel Kahneman's seminal work on cognitive biases and decision-making has profound implications for critical thinking in psychiatry. His distinction between System 1, fast thinking, and System 2, slow thinking, offers a valuable framework for understanding both the potential and pitfalls of clinical reasoning in mental health settings. When we examine these concepts in the context of psychiatric practice within the NHS, we discover both illuminating insights and concerning tensions. The dual systems of psychiatric reasoning. Kahneman describes System 1 as our intuitive, automatic thinking process. It operates effortlessly, drawing on heuristics and pattern recognition to make rapid judgments. In psychiatric practice, System 1 manifests when we immediately recognize familiar symptom clusters or when experienced clinicians have intuitive gut feelings about diagnosis or risk. Consider the psychiatrist who instantly recognizes the pressured speech, flight of ideas, and grandiosity that characterize mania, or who intuitively senses risk factors for suicide based on subtle verbal and nonverbal cues. Or consider a psychiatrist who spots catatonia and decides this must be catatonic schizophrenia, he needs a course of lorazepam. These rapid assessments rely on implicit knowledge developed through years of clinical experience. By contrast, System 2 involves slow, deliberate, analytical thinking that requires sustained attention and effort. This is the domain of critical thinking proper, the careful analysis of evidence, consideration of alternative hypotheses, and systematic evaluation of our reasoning. In psychiatry, System 2 thinking occurs when we methodically work through evidence, consider alternative explanations on the way to differential diagnoses. Sound critical thinking means that we carefully weigh the benefits and risks of different treatment options, or when we intentionally challenge our own initial impressions of a patient. It involves asking questions like, what evidence contradicts my working diagnosis? Or, how might this patient's cultural background and other factors influence my interpretation of these symptoms? This deliberate reasoning demands cognitive resources. It is the correct path to more accurate assessments. Critical thinking as predominantly slow thinking. Critical thinking in psychiatry unquestionably aligns more closely with Kahneman's System 2. The core activities of critical thinking, analyzing complex information, questioning assumptions, considering context, and reflecting on our own thought processes, all require the deliberate, effortful cognition characteristic of slow thinking. This is particularly true in psychiatry, where the evidence is often subjective, presentations are frequently ambiguous, and contextual factors significantly influence both expression and interpretation of symptoms. The analytical nature of critical thinking demands cognitive space and time that System 1 thinking simply cannot provide. When evaluating whether a patient meets criteria for involuntary treatment under the Mental Health Act, for instance, we must carefully consider multiple factors, the nature and severity of their mental disorder, the risks to themselves and others, their capacity to make treatment decisions, and less restrictive alternatives to hospitalization. Each element requires careful assessment rather than rapid-fire judgments. Similarly, when distinguishing between psychotic depression and schizoaffective disorder, we must systematically evaluate the temporal relationship between mood and psychotic symptoms, the nature of the thought content, and the longitudinal course of illness. These complex clinical judgments cannot be reliably made through System 1 processes alone. Moreover, critical thinking involves metacognition, thinking about our thinking, which is quintessentially a System 2 process. We must step back from our immediate impressions and examine our reasoning. Am I overvaluing certain symptoms because they fit my working diagnosis? Or, might my emotional reaction to this patient be influencing my clinical judgment? Or, is this a political situation? Who am I serving? This reflective stance is impossible within the rapid, automatic processing of System 1. It requires the deliberate self-monitoring that only slow thinking provides. The NHS context demands for fast thinking crowds out critical thinking. Despite the clear importance of System 2 processes in psychiatric assessment, the realities of NHS practice often favor System 1 thinking. Resource constraints, high caseloads, and institutional pressures for efficiency create conditions where fast thinking becomes the default mode rather than a complement to more deliberate reasoning. In acute settings particularly, the expectation of rapid assessment and disposition decisions can leave little room for the reflection and analysis that critical thinking demands. Seeing, assessing, a patient is just the beginning of the work. What about documentation, including decision-making? Consider the junior doctor, JD, conducting an on-call psychiatric assessment in a busy A&E department. With other patients waiting and pressure to free up cubicle space, there is little opportunity for the careful consideration of multiple hypotheses or exploration of contextual factors. JDs are not independent practitioners. They must upscale their assessments with appropriate supervision, even when tired or overworked, by reviewing cases with a consultant. In community settings, high caseloads and brief appointment slots can push even experienced psychiatrists toward cognitive shortcuts and heuristic reasoning rather than comprehensive assessment. When a consultant is asked to see 15 patients in a 4-hour clinic, System 1 thinking becomes not just tempting but seemingly necessary. What about documentation, including decision-making? These pressures toward fast thinking carry significant risks. Reliance on System 1 processes makes us vulnerable to numerous cognitive biases that can compromise clinical judgment. Confirmation bias leads us to notice evidence that supports our initial impression while overlooking contradictory information. Availability bias causes us to overestimate the likelihood of diagnoses we've recently encountered or that are particularly memorable. Anchoring bias makes it difficult to revise initial assessments even when new information emerges. The fast-paced NHS environment can amplify these biases by reducing opportunities for the deliberate reflection that might otherwise identify and correct them. The costs of these cognitive shortcuts can be profound. Misdiagnosis may lead to inappropriate treatment, with patients receiving medications with significant side effects for conditions they don't have. Premature closure, settling on a diagnosis before adequately considering alternatives, may result in missed comorbidities or failure to identify physical health conditions presenting with psychiatric symptoms. Perhaps most troublingly, cognitive biases can disproportionately affect assessments of patients from marginalized groups. Research suggests that Black patients are more likely to receive severe diagnoses like schizophrenia and less likely to receive diagnoses like depression compared to white patients presenting with similar symptoms, a disparity that likely reflects, in part, the influence of implicit biases on clinical judgment. Finding balance, integrating fast and slow thinking in clinical practice. While recognizing these challenges, we must acknowledge that neither system of thinking is inherently superior. Even Kahneman emphasizes that both systems serve important functions, and effective reasoning involves their appropriate integration. System 1 thinking allows experienced clinicians to rapidly recognize patterns and respond to emergencies, while System 2 thinking enables careful analysis of complex cases and correction of potential errors. The challenge in psychiatric practice is not to eliminate fast thinking but to deploy it judiciously and complement it with deliberate reasoning when needed. At a systemic level, NHS trusts must recognize that meaningful psychiatric assessment requires time for reflection and analysis. The drive for efficiency must be balanced against the cognitive demands of complex clinical judgment. This may require advocating for reasonable caseloads, appropriate appointment lengths, and administrative support that frees clinicians to focus on clinical reasoning rather than paperwork. By acknowledging the cognitive processes underlying effective psychiatric practice, we can design systems that support rather than undermine critical thinking. In essence, Kahneman's work reminds us that critical thinking in psychiatry is a skill and a practice that requires conducive conditions. When we understand the relationship between fast and slow thinking, we become more aware of the value and limitations of our intuitive judgments and more intentional about creating space for deliberate reasoning. This awareness itself constitutes a form of critical thinking, a metacognitive stance that helps us navigate the complex interplay between efficiency and thoroughness in modern psychiatric practice. Conclusion: critical thinking as the heart of psychiatric practice. Critical thinking stands is not simply a useful skill. It is the very foundation of thoughtful psychiatric practice. Throughout our exploration, we have seen how this multifaceted cognitive discipline transcends simple logic to encompass analysis, evaluation, contextual awareness, emotional intelligence, and metacognitive reflection. In psychiatry, where subjectivity reigns and certainty often eludes us, these thinking skills become our most reliable instruments. The psychiatric profession operates at a unique intersection of science and humanity. We navigate a terrain where biological factors intertwine with psychological experiences and social contexts, the biopsychosocial model. Our environment is essentially a place where cultural meaning shapes symptom expression, and where ethico-legal considerations permeate every clinical decision. Critical thinking provides the intellectual framework that allows us to honor this complexity rather than reduce it to simplistic formulations or diagnostic labels. Kahneman's insights into fast and slow thinking remind us that critical thinking requires both cognitive space and institutional support. The pressures of NHS practice, with its resource constraints and efficiency demands, create an environment where thoughtful deliberation becomes increasingly difficult. Yet it is precisely these pressures that make critical thinking most essential. When time is limited and decisions carry significant consequences, the ability to think clearly, evaluate evidence judiciously, and remain aware of our cognitive biases becomes not a luxury but a necessity. For the developing psychiatrist, cultivating critical thinking involves more than mastering diagnostic criteria or treatment algorithms. It requires developing a questioning stance toward knowledge, maintaining curiosity about the diverse contexts of human suffering, and practicing ongoing self-reflection. It means recognizing that psychiatric diagnosis is not an end in itself but a means of understanding experience and guiding intervention. Perhaps most fundamentally, it involves acknowledging the provisional nature of our understandings and remaining open to revision in light of new evidence or perspectives. As we practice psychiatry in an increasingly complex healthcare landscape, critical thinking serves as both compass and anchor. It guides us through ambiguity while keeping us grounded in evidence and ethical principles. It helps us resist both therapeutic nihilism and overconfident intervention. And ultimately, it ensures that even as we employ the language and tools of medicine, we never lose sight of the unique persons whose lives we are privileged to enter. In this way, critical thinking represents not just good reasoning but good medicine, a practice that honors both the science of psychiatry and the humanity of those we serve.